Hello, my name is Christine Morales, and I'm going to be presenting for the Unit 4 Case Connections. So the first case that I chose is Case 1. Here the patient is a newborn girl who initially appeared normal but later developed symptoms of being lethargic, hypothermic, and had apnea, which is difficulty in breathing. So the attending physician ordered a panel of labs, and from these choices, I need to pick which one would be the best to distinguish between a disorder of the urea cycle and a disorder in beta oxidation. So my four choices for the panels are blood glucose, urinary acids, serum fatty acids, and plasma glutamine. I believe that plasma glutamine would be the best panel to utilize. If there was something wrong with the urea cycle, then the glutamine levels wouldn't be normal. There would be something wrong with them. But if there was something wrong with beta oxidation, however, then these levels would appear normal. So this test would allow one to determine if there was a disorder with the urea cycle or if there was a disorder with beta oxidation. I also believe that this is the best test because glutamine's role in the urea cycle is to fix and free ammonia so that it can be transported safely and then excreted later as urea. The panel for blood glucose isn't a viable choice because although a deficiency in blood glucose could mean that there's a deficiency in beta oxidation, it's not specific enough to say that beta oxidation was the cause for abnormal blood glucose levels. For example, abnormal blood glucose levels could instead be caused by the individual being diabetic. So we have to keep in mind that this is a newborn baby girl. It appears that she was born within the last 24 hours, and there's something called gestational diabetes. This is when a pregnant woman who has never had diabetes can have high blood glucose levels due to insulin resistance. And if the mother continues to have increased blood glucose levels despite insulin trying to do its job, the extra glucose will then travel through the placenta and give the baby high blood glucose levels. This is something that this panel would detect, but would not necessarily be due to a defect in beta oxidation. That's why I believe we can cross out the panel for blood glucose. The panel for the urinary acids is also incorrect because this can be influenced by external factors as well, like medication that might still be in the baby's system from the mother's labor. An example of this would be morphine, which of course is given to the mother so that she's not in as much pain when in labor. And this could lead to an increase in uric acid because the morphine could increase the xanthine oxidative metabolism. So this could also show up in the baby's blood panel, but it wouldn't be because of something that is wrong with the baby. It would be something that is left over from the labor. So that's why we're also going to cross off urinary acids. Now the panel for the serum fatty acids is also incorrect because this wouldn't tell if there's a defect in the urea cycle or even the beta oxidation. This really just tells if the levels of the beneficial fatty acids are enough. So we can just cross this out, which left us with a choice of plasma glutamine being the correct answer. So a full blood workup was also ordered for this patient, and the results are shown here below. To summarize, both her initial anomia and her urine orotic level were elevated, and the ammonia was further elevated, whereas her plasma citrulline level was normal. I need to determine what urea cycle enzyme is most likely to be deficient in this patient with an elevated orotic acid levels and which is least likely to be impaired. The enzyme that is least likely to be impaired would be carbamoyl phosphate synthase, which is also abbreviated as CPS. We can see it here in this picture. This is actually a diagram of the urea cycle. So this enzyme is least likely to be impaired because this is the only regulatory step in the urea cycle. It's if there was a defect with this enzyme, then there would not be an increase in ammonia nor enough carbonyl phosphate to make orotic acid later. Since there's an abundance of ammonia and then thus likely the carbonyl phosphate, it is likely working just fine. In fact, the enzyme that is most likely to be impaired in this case would be ornithine transcarbamylase, which here is instead written as ornithine carbonyl transferase. A deficiency in this is what caused the further increase in ammonia levels later, and the carbonyl phosphate from before this enzyme is utilized as shown here. It would have participated in pyrimidine synthesis in the cytosol, which is what later resulted in the high levels of orotic acid. It's said that the citrulline levels were normal, but if you see here, it's a little bit below normal, and I believe that is because there was enough excess carbonyl phosphate to make citrulline. It's just that more of it was making orotic acid, and that's why the levels are slightly below normal. Lastly, when I searched symptoms of ornithine deficiency, the same symptoms that the newborn girl presented with, lethargy, hypothermia, and apnea, were also with the regular symptoms of this. So the second case I am going to be talking about is case 3. And in this case, a 47-year-old man is diagnosed with gout. So to summarize, he has high plasma urate levels and low urinary uric acid levels. And I need to pick the best explanation for his presentation of gout from the overproduction of purines, the decreased salvage of purines, or the decreased urinary excretion of uric acid. It should be noted also that the patient tells that he had been drinking 4 to 5 liters of soda a day, and that he switched from fake sugar soda to regular soda. And one of the primary sugars in regular soda is fructose or high fructose corn syrup. So based on this data, I believe the best reason for his presentation of gout is due to the overproduction of purines. I believe it is not caused by the decreased salvage of purines because there was an increase in his plasma urate, and therefore there was not a decrease in purine salvation. By definition, urate is a salt or an ester that is made from uric acid. Furthermore, the decreased salvage of purines is due most likely to an enzyme deficiency, like the enzyme that is needed for purine recycling, which is hypoxanthine guanine phosphoribosyl transferase, which is commonly associated with the disease Lesch-Nyhan syndrome. I'll write it down in case. It's spelled kind of funny. There was no mention of this syndrome, and it should be mentioned because it would be pretty significant. Furthermore, if this man was deficient in this enzyme, he would have had problems earlier in life that would have resulted in more serious symptoms that would have brought him to the hospital sooner. For example, he would have self-mutilating behaviors or like impaired kidney function, again, of which there was no mention. If this was determined to be the probable cause, then genetic testing would have to be done to ensure that he doesn't have Lesch-Nyhan syndrome. So we're going to cross off the decreased salvage of purines as incorrect. Now for the decreased urinary excretion of uric acid, I also believe this to be incorrect. There just isn't enough information to justify this answer. To determine if this was the cause of his gout, a more detailed medical history would need to be taken, specifically about his alcohol consumption, and additional lab work would be needed also, because the primary cause for the underexcretion of uric acid is excessive alcohol consumption. This happens because the alcohol consumption will increase the production of lactic acid, which would then compete with the uric acid for excretion. So therefore, we're also going to cross out choice number 3. However, the overproduction of purines is supported, especially if we take into account that the patient is consuming between 4 to 5 liters of regular soda a day. The explanation as to why this is correct will also help answer what impacts this action could have on the presentation of gout. So as mentioned, the primary sugar in most sodas is fructose or high fructose corn syrup, and this would cause an increase in the uric acid levels, especially when you compare it to when he was just drinking diet soda. Fructose is a natural sugar that gets metabolized into fructose 1-phosphate by fructokinase. So a phosphate is just added onto it. And then catalase B will then break apart the fructose 1-phosphate into dry hydroxyacetone phosphate, also known as DHAP, and D-glyceraldehyde. And since its intake of fructose is so high, the phosphorylation of fructose into fructose 1-phosphate will be fast, but the reaction with catalase will be slow. This then leads to an accumulation of fructose 1-phosphate, but also a decrease of intracellular phosphate, since this is what is being added onto the fructose. So this stimulates AMP deaminase to degrade AMP into IMP, also known as inosine monophosphate, which will then cause an increase in the rate of purine degradation due to providing an important base, thus leading to the overproduction of purines, since they can be made de novo or from salvage pathways. So that explanation actually tells us why choice 1 is the root cause of his gout, and why him drinking fructose, what kind of impact does it have on his presentation of gout.